day, dear listeners. The theme of lecture is ENURESIS. Definition: involuntary voiding of urine at least 2 nights per month beyond the age of 5 years, by which bladder control is normally obtained and without any congenital or acquired defects of the urinary tract. Types of enuresis: primary, child who never gained nocturnal urinary control, accounts of 85 of cases. Secondary, at least a 6-month period of dryness has preceded the onset of wetting. Type 1, monosymptomatic. Type 2, diurnal enuresis with daytime frequency. Type 3, nocturnal enuresis with daytime frequency and voiding dysfunction. Types of enuresis: uncomplicated, is onset primary, daytime symptoms are absent, physical examination is normal, urinalysis is normal. In complicated form, onset is secondary, daytime symptoms are present, physical exam is abnormal, urinalysis is abnormal. Therapeutic responses: initial success: 14 consecutive dry nights have been achieved with treatment. Lack of success: failure to meet the above criteria. Relapse: when 2 or more wet nights within 2 weeks of initial success. Between initial success and relapse measured. Continued success: there is no relapse after 6 months of initial success. Complete success: in 2 years after initial success. Development of urinary control: 1. Nocturnal bowel control. 2. Daytime bowel control. 3. Daytime voiding control. And 4. Nighttime voiding control. Genetics: 1. Familial patterns. 2. Risk of enuresis: 7.5 when father was enuretic than when mother was. 3. 75% is both parents were enuretic. 4. 45% in families with one parent enuretic. 5. 15% when neither of parents were enuretic. 6. Primary out dominant with penetrance above 90% with disease locus of chromosome 13q. Types of nocturnal enuresis: monosymptomatic, solely nocturnal, normal physical examination and ureterogram, and no further investigations. Polysymptomatic types of enuresis have daytime enuresis, urgency, dribbling, neurological abnormalities, and urinalysis. Symptoms: need contrast studies, urodynamic assessment. General treatment: 1. Avoid excessive fluids. 2. Empty bladder at bedtime. 3. Told to wake up at night and use toilet to remain dry. 4. Improve access to toilet. 5. Include the child in morning cleaning up of urine silent cloth. Behavioral inversion. First, active precipitation and the parents. Second, the child and the precipitation. Motivation therapy. 1. Convince parents that the child wants to be dry. 2. Child is encouraged to assume responsibility for his enuresis and actively participate in treatment. 3. Move from blame for wet nights to praise the dry nights. 4. A dry morning should receive positive recognition and should receive lavish words of praise from everyone in family. 5. A major breakthrough may warrant material reward. Alarm therapy. 1. Alarm triggered when the theater gets wet to awaken the child from sleep and nocturnation. 2. By repetitive inhibition of micturition, a condition process occurs ultimately. 3. With 3 months of treatments, 92% cured. 4. Relapse rate is 30%. 5. Response to treatments is good. 6. Adjuvant pharmacotherapy helps. In this slide showed wet alarm therapy. Pharmacotherapy. First, vasopressin for 4 years old reduces nocturnal urine output to a volume lower than functional bladder capacity. Useful in those who don't manifest diurnal rhythm of vasopressin. Dose 20 micrograms one spray to each nostril. Max up to 18 micrograms. Adverse effects are hypothermia, disorientation, seizures, and coma. Second, anticholinergics acts by increasing bladder and reducing frequency of detrusor contractions. Adverse effects: dryness of mouth, blurred vision, and facial flushing. Dose for 7 years old, 5 mg 2 or 3 times a day. Third, tricyclic antidepressants. Alternation of sleep mechanisms and arousal patterns, cholinergic properties. Adverse effects are anxiety, insomnia, dry mouth, nausea, personality changes, cardiac arrhythmias, hypotension, respiratory complications, and convulsions. Dose 25 mg for 6, 7, and 8 years old, 15, 75 mg for older children administered at 6 p.m. Treatment for 3 or 6 months, then period of physostigmy. And surgical therapy is hysteroplasty in select cases. Thank you for attention. See you next time.